Hi, everybody. Welcome to the Hope for Mental Health community. I'm so glad you've joined us today here on February 28th. It's just good to have you. One really exciting thing that I want to tell you about before we talk about today's program is that on March the 27th, Saturday, March 27th, we're going to have an online half-day retreat for parents of children of any age who are living with a mental illness. We're calling it Breathe. We did a live one of these for moms back in November of 2019 and have not been able to resume those in-person ones. So we're going to just cooperate with COVID stuff and have it online. But there'll be a link in the notes in the chat for you to look at where you can sign up. But I really encourage, it's for parents. I'll be sharing, I'll have some fun features. We'll have some breakout rooms where, if you have a child with a specific illness, hopefully we'll be able to have a breakout room for you, some special treats. And so look for that. Everybody needs some encouragement if you are a parent of a child living with mental illness. So I encourage you to look for that. So today I'm really thrilled to have Dr. Aaron Carriotti join us. It's taken about a year to try to get our schedules to mesh, but they finally have. And he is a psychiatrist, author, and professor at the University of California, Irvine. He's also the director of the medical ethics program at University of California, Irvine Health. He obtained his medical degree from Georgetown University and is the author of many books and articles for professional and lay audiences, including The Catholic Guide to Depression. He lives with his wife, Jennifer, and his 5 sons here in Orange County, California. Dr. Kheriaty and I got to know each other about a year after my son, Matthew, died. He was one of our speakers at our first mental health and the church conferences. And I was so impressed with the expertise and the knowledge he has, but even more so, I was impressed with his very strong Catholic faith that informs both his practice and his way of relating to people, but also just his heart of compassion for people who are suffering from mental health challenges. I've seen his work firsthand, and I have the utmost respect for him. So join me in welcoming Dr. Aaron Carriotti. So it has taken us a year to get our schedules together, Dr. Kheriaty, but that's okay. I said, you are worth waiting for. We are just so glad that you're joining us today. And before you talk to us a little bit about depression, I would just like it if you would tell our audience a little bit about your family, and then I'm going to ask you about like how you got into the field. But first of all, just tell us a little bit about your family.
Sure. So first, Kay, thank you for the invitation to speak. I'm really delighted that we're going to be talking about depression together today, and hopefully I can make a little bit of a contribution to your mental health outreach. I just have tremendous respect for the work that you and the others at Saddleback and have done to reach out to individuals who struggle with mental illness, to their families, to all those who are trying to care for them and assist them. So I'm really delighted to be here. I live and work here in Orange County. I'm the father of 5 children, all boys, all of the male variety.
You're a boy dad.
I'm a boy dad and married to my wonderful wife, Jennifer. We were high school sweethearts, so we go back quite a ways. Our oldest son is a sophomore in college, and our youngest is in 3rd grade. So we have a pretty good age span, and it's delightful just to watch them grow up. And they're all so different, which is amazing. Just the variety and diversity that God has blessed my family with.
I always thought that that I was a pretty good mom until I had my second. And then by the time I had my 3rd, I decided I was a complete novice because each one of them was so different.
They're different. They're different. And none of them comes with, an instruction manual tucked under their arm. So you have to try to relearn the parenting thing with each new one. I'm automatically skeptical of anyone who claims to be an expert on parenting.
Yes, I'm with you on that. Well, listen, from reading your bio and stuff and what I know of you, you were a philosophy, that was your major in college. So I am really curious how you moved from philosophy to psychiatry. Um, what drew you to this field of study? What was that transition like, or tell us about that?
Sure. So I fell in love with philosophy as an undergraduate, and I was attracted to this field that tried to explore some of the bigger questions in life. Where did we come from? Where are we going? What is the purpose of a human life? What is our relationship to something higher, to the transcendent? And of course, philosophy needs theology to fully answer those questions, but I loved exploring those questions of deeper meaning and purpose and what a well lived life might look like. But I was also interested in science and medicine. So I had a pre-medical degree as well from Notre Dame, and went back and forth. But my then girlfriend, now wife, convinced me that maybe if I did medicine, I could explore both domains. Whereas if I just pursued academic philosophy, I would be more restricted. And she was absolutely right about that. I've found that medicine, and particularly psychiatry as a specialty, is a really interesting place to kind of return to those same questions when people suffer from illness. And I think particularly perhaps when they suffer from mental illness, those questions become all the more pressing. If God is good, why is he allowing me to suffer this way? This is not just an abstract philosophical question that I've considered in the classroom, right? The classic problem of evil. But this is also a question that many patients have put to me. It's not a question I claim to have an answer to, but it's certainly one that many of the folks that I try to help are struggling with. And we could go on in a similar vein about other issues. So in my own experience, my background in philosophy has helped me not just in my work with medical ethics, but also in my work as a psychiatrist, where the illness seems to touch people at a very deep level, right? Questions about identity come up. Is this me, or is this my illness, right? What was my bipolar mania versus what was actually my own free choice? These are hard questions that, again, are, we can philosophize about in an armchair fashion, but they're actually questions that real people, ordinary individuals, are struggling with. And so it's been a real privilege for me to kind of explore those interests in the context of practicing medicine, and specifically as a psychiatrist, trying to help folks that are struggling with mental illness and addictions and disorders of that type.
Well, and I mentioned in the introduction that you're also a man of deep faith. You're a practicing Catholic. This is integral. Your faith is integral to who you are, and we'll talk about that more as we go along. Even just that combination of faith, psychiatry, philosophy, because we'll talk about this. But psychiatrists are not necessarily known to be people of faith. That is not exactly. You think faith, psychiatry, you don't necessarily put those two together. And some of the people
Right.
who are watching have probably really experienced that lack of understanding from their medical professional about their faith. So we'll come back to that. But for now, just take us through, talk to us about depression, talk to us about, well, anything that you think will help set up the rest of what we're going to say today. So please go ahead, just share with us.
So as I said in the introduction, I'm really glad that we're talking about depression, because it's an illness that affects so many people, even before the coronavirus outbreak and the consequent lockdowns and all of the challenges and difficulties that we've been dealing with in the last year. Even prior to that, there were concerning signs that the rates of depression were on the rise. And Kay, as we'll talk about later in our conversation, that has been even further exacerbated by what has happened in the last year worldwide and all of the challenges associated with the current pandemic. So it's something that impacts many people. But at the same time, it's an illness that lots of folks don't understand very well. And I think one of the difficulties is that depression is one of those words that people use in ordinary conversation all the time. I hit a rough patch in life. I notice that my mood or my emotional state is a bit low for a day or two, and I tell people that I'm depressed, which in some sense is a perfectly legitimate thing to say, or a perfectly acceptable way of describing my current emotional state. But when psychiatrists or physicians or psychologists or other clinicians talk about depression, talk about a clinical syndrome that can severely impair a person's functioning, we're not just talking about an illness that affects one's emotional state, although that certainly is part of it, but we're talking about an illness that affects not only our emotions, but our cognitions, our ability to think clearly, our physical functioning, right? So just going through some of the basic signs and symptoms of depression, we see not only mood changes, either feeling numb or feeling a pervasive kind of sadness that is difficult to square with my circumstances, but also difficulty focusing and concentrating. People that are clinically depressed will say, I can't track in a conversation. It's hard for me to read. I've read this paragraph 4 or 5 times. I have to go back and read it again, and it's still not sinking in. So it's not just my emotional state, but it's my ability to think clearly that's impacted by this illness. People's appetite and sleep and levels of physical energy can be severely disrupted with depression. So very often people present to their primary care physician, to their family doc or their internist, with physical symptoms or physical complaints, and the diagnosis turns out to be depression. And that's not because they're faking physical symptoms at all. It's because depression very often has symptoms that manifest on the physical level, with gastrointestinal symptoms, for example, being very common, headaches being very common, other what we call somatic or bodily symptoms of depression. People can have profound changes in, as I mentioned a few minutes ago, in their sleep cycle and in their appetite. They can have very clinically significant weight loss. In some atypical forms of depression, they can have clinically significant levels of weight gain, right? So the sleep and appetite changes with depression usually go in the direction of difficulty sleeping, insomnia. Early morning awakening is very typical. I wake up at 3 or 4 in the morning, I can't get back to sleep, and yet I'm still exhausted because I'm not sleeping enough, or because of the depression. Or weight loss and diminished appetite. But in some cases of what we call atypical depression, the changes can go in the opposite direction. So we could see people sleeping 18, 19 hours a day in a 24-hour period, and still reporting that they feel exhausted. Then the few hours that they're awake, they find it hard to get out of bed. So we see profound physical and physiological changes that affect people and their ability to do basic activities of daily living. So people who look fine on the outside, right? This is not like a broken arm or a broken leg where it's obvious where the physical impairment comes from. But nevertheless, people reporting it's hard for me to just brush my teeth or take a shower or do very basic activities of daily living to care for my grooming and hygiene, or other simple tasks, otherwise simple tasks like that. Unfortunately, depression is also commonly associated with a sense of hopelessness and the feeling like I'm suffering unbearably and I can't go on anymore, which can lead many individuals suffering from depression, who otherwise would never consider wanting to end their life or make an attempt on their life, to say, I don't know if I can continue like this. And they can develop the mistaken notion that maybe my only escape from this is suicide. Now, of course, that's a trick of the diseased mind. It's never the case that someone's situation is hopeless, or that suicide is the right solution to depression. But the depressive mindset can begin going down that route. So suicidal thinking can become very common in depression, even unfortunately among individuals who otherwise, for moral or religious reasons, would never consider suicide, and would have an understanding that my life is not mine to take. It was a gift from God, and I need to steward it. Well, um, certainly religious belief and religious practice and religious faith, as we'll talk about perhaps later in our conversation, can help lower a person's risk for depression. But those things don't inoculate us from either depression or from the worst outcome, which would be dying by suicide. So those are some of the basic signs and symptoms of depression. And folks may ask, well, maybe I have a few of those symptoms, or maybe I hit a period in my life where for a couple of weeks experiencing some of those things. How do I know when I've crossed that threshold where now it's time for me to seek help? Maybe I'm reluctant to put myself under the care of a psychiatrist because of the unjust and unfortunate stigma against mental illness or mental health issues. Or maybe I'm reluctant for various reasons to take a medication to try to help me with depression. When should I go seek help from a psychiatrist or a psychologist or a primary care physician or someone else who can evaluate my condition? I would say a good rule of thumb is if you get to the point where for a week or two, these symptoms are impairing your ability to do the things that you would ordinarily do, then it's probably time to reach out for help. As I said a few minutes ago, all of us hit a rough patch where we may have a day or two of the blues, or a day or two where we don't want to get out of bed because we're dealing with a major life issue. But if that persists for a couple of weeks, and we've gotten to the point where it's become difficult for us to care for our children, difficult for us to accomplish tasks at work that we would ordinarily not have a lot of difficulty with, difficulty for us to connect and relate to other people, so our relationships are suffering with loved ones or with family and friends, I would say once these symptoms, or this collection of symptoms, gets to the point where it's impairing your ability to do the things that you're called to do, to live out your daily vocation as a husband or wife, as a parent, a mother or father, as a professional, then we've gotten to the point where I think it's worth your while to go seek help and at least get an evaluation, at least get some information on depression. Because if you wait too long and the symptoms become more severe and your functional impairment becomes more pronounced, the illness in the more severe stages is usually harder to treat than when it's in the mild or mild to moderate stage. So waiting longer than you need to is usually not helpful, because that can mean that recovery may take longer than it otherwise would have. So if you think there's an issue there, try to overcome whatever barriers, whether it's stigma or the shame of feeling like there's something wrong with me, which is not the case. You're suffering from an illness through no fault of your own, or you may be, and it's worth going in to get an evaluation and get that looked at, just like you would go see the doctor if you were having symptoms of a medical illness or physical symptoms that were causing some impairment in your ability to function.
Thank you for that. That's such a helpful explanation to people of some of the basics about depression. We've been doing this Hope for Mental Health community for a couple of years, but we always have people who are joining in for the first time. And, I think even during COVID, there are people who are maybe experiencing depression for the first time, and they just might not even recognize that what they're feeling is depression, or maybe I would even say, I think most of us are depressed to some level or the other,
Yep.
just because of the chaotic nature of our world right now. But before I do that, I really want to go back to, because that actually brings up what I wanted to say. I read in your book, The Catholic Guide to Depression, which is a really good book, by the way. Um, I'm quoting from it. You say the very word depression probably does not do justice to the reality of this affliction. Depression suggests a slight dip on a flat surface like a depression in the road. The experience of depression, by contrast, is not just a dip, but a dark and miserable pit. It is an intense and serious cause of mental, physical, and spiritual suffering. Many of us who have not been visited by this affliction might mistakenly believe that we know what depression feels like. This assumption is mistaken. I've cut some words just for length here.
Yep.
There are some similarities to feeling down, but depression is really another animal altogether. And so in these times of COVID, like I said, there are probably some people who are experiencing clinical depression. They don't know it. They, like I said, they're looking at everybody else who's saying, yeah, I'm struggling, I'm feeling down, I'm really having a hard time. How, particularly with the world so turned upside down the way it is right now, what is the difference between the normal human experience of feeling sadness or depression or anxiety with all that's going on? How do we
Yep.
distinguish, and just, even if you wouldn't mind just addressing a little bit further that idea that those of us who might feel that somehow think we know what
Right.
depression feels like.
Yeah, so that's a terrific question. And I do want to acknowledge, um, without necessarily saying that it's the same as clinical depression, that, as you said, all of us are suffering during this pandemic. And many more of us are suffering from levels of depression that cross that threshold, into the kind of state of mind, uh, where even if my external circumstances can change, maybe the stress of unemployment is gone because I got a job, the depression itself can take on a life of its own. And so the first thing that I'll say is the rates of more serious levels of depression have risen during COVID. So usually, depending on the criteria that's used to diagnose it, but according to pretty standard clinical criteria, which is having a collection of 5 or more of the symptoms that I described for a period of 2 or more weeks, uh, at a level that again impairs your functioning in a significant way, right? Changes your ability to go through your ordinary day and do the things that you would ordinarily do, not for a day or two, but for a persistent period of time. That level of depression usually hovers around 6% of the population at any given time are struggling with uh, depression at that level, which is a very significant number. Um, that's nothing to sneeze at, certainly. But one CDC study that was done looking at Americans last June, this was a population-based study of about 5,000 people, which means it's well designed and it should represent the experience of most Americans, suggested that rates of clinically significant depression during that month last year were somewhere in the neighborhood of 24%.
Wow.
So almost a quadrupling of rates of depression in the last year, the kind of, or the level of depression that might require clinical attention. So I think that all of us, by analogy, can feel our way a little bit into the experience of depression. But I don't think that we should assume that because all of us have dealt with difficulty or stress or hit a rough patch that affected our mood for a period of time, that we necessarily know what it's like to experience clinical depression, the kind of psychological or mental moment to moment pain. And people who struggle with depression describe it in terms of pain, that somehow the closest analogy they can come up with to what they're experiencing on the inside is physical pain, except it's not physical pain it's occurring mentally. So again, difficult to describe using analogies and metaphors. Um, but I think it's important for folks to appreciate that, if my spouse is suffering from depression, just because, I've had a rough time in life here and there, that I automatically know what they're going through, or that what worked for me to kind of pull myself up by my bootstraps is automatically going to work for you. I think we have to be careful. We do want to empathize with folks, but we need to approach that with some degree of humility, that perhaps what my loved one is experiencing goes beyond anything that I've experienced. And I can try to empathize as much as I can, but I shouldn't necessarily assume that I know exactly what they're going through.
Yeah, I think that that is um, one of our common responses. I think when people tell us something about themselves, is in our effort to, I don't know if it's identify with them or to just interject our own story into it. We're pretty quick to say, "Oh, I know exactly how you feel," or "I know how you feel," and then we might say something like, "Yeah, when I lost my job, I was so down." And that is not minimizing at all the fact that that brought losing your job did create sadness, did create feelings probably of some moments of, will I ever get a job? I mean, those are normal responses from what I have figured out. But
Sure.
that is so different from what you are describing. And I like what you said about just having that family members, friends, roommates, coworkers, to not be so quick to that, "Oh, I know how you feel," because actually clinical depression, as you wrote, it is a dark and miserable pit. And I think about my son Matthew and the 20 years that he lived with clinical depression, starting when he was 7.
Yeah.
We just didn't even know that children could experience depression. It's not all that common, but because it was so rare, and this was, a long time ago, we didn't even know that a child could have clinical depression. But over
Right.
those 20 years, when he would try to put into words what he was feeling, I still don't know after all this time if I can think, when I read that, a dark and miserable pit, I go, yes, that is what he was feeling. But even if I were to put more and more words to that, it's still, I can just see all the times when he would just look at me with this expression on his face of such helplessness to be able to tell me just how bad it really, really was. So I only have that to say. I can definitely say there's a difference between the depression that I feel like I've lived my whole life and
Right.
this depression that for him ultimately was, it was fatal. It was
Right.
a fatal
Right.
depression. And so I really like that for anybody, any family members, or you love someone who is depressed, and love someone, is is to not is to not act like, in your effort to be kind and empathetic, that you somehow make them feel like when you don't. That's, to me, that's a really good piece of advice. But let's just say you do love someone who has this kind of a depression. Um, what can family members, how can they help? What should they avoid? What should they be? We've talked about one thing, being careful to not say, "Oh, I know how you feel." But
Right.
what else can they do both positively, and what can they maybe avoid?
That's a great question, and I completely agree with your remarks about these efforts toward empathy that may inadvertently backfire and actually make the person feel more understood.
Yeah.
Right? It would be better if you were able to say to them, "I don't know what it's like to be in your shoes right now, but I love you and I want you to know that I'm here for you." So my first piece of advice is listen to them, let them do the best that they can to articulate their experience, and understand that they're probably not going to be able to completely or satisfactorily articulate their experience. But to the degree that they want to talk about their experience, just be open and available and ask them questions. Obviously, stay close to them, pray for them, tell them that you are praying for them and make them feel your presence, even if that's just a physical presence without having to say anything or do anything to fix the problem, which is really hard for families, and especially for certain personality types who are fixers. Okay, let me figure out what you need. I went on Google and I found all
Yeah.
these remedies for depression, and I found the expert. This is the guy you got to go see. Okay, some of those things may be helpful, but to attempt to kind of manage the person's life in an overbearing way that may be stifling may not be exactly what that person needs in the moment. So what can you do? One thing that you can do is to tell them that you understand that they're suffering tremendously, and even acknowledge, and I do this as a psychiatrist too, and I'm the one who's supposed to be, treating this illness, and I will treat the illness, but I first acknowledge that if you come to me in a state of clinical depression, I know that you're suffering tremendously, and I know there's nothing that I can say or do that is going to fix it for you today, right? That the treatments, whether antidepressant medications or psychotherapy or treatments for severe refractory depression that doesn't respond to other things like procedures like TMS and ECT, which we can talk about later, none of these things work overnight. Medications take at least a month to take effect. Psychotherapy can take that long, often longer, to get the full benefits from. And so I acknowledge that I wish I did have something I could give you to make this depression lift today or tomorrow or even next week. I don't, but I want you to know that there is hope for you. I want you to know that this illness is treatable. And if you persevere with treatment, if you continue to follow up with me, if you continue to work on these things outside of our sessions that I'm recommending, I am very confident that we will find something that works for you and that you will be able to recover and you will be able to get better. And that is a helpful and necessary message. It's also a message that can lower their risk of suicide while they are struggling to recover from an episode of depression. People need to be educated that if I've been on my antidepressant medication for a week or 2 weeks and I haven't seen any effect, that's not a reason to despair. We know that the medications take longer than that to work. So that can sort of paradoxically be a high risk period. For people making a suicide attempt or tragically completing suicide is shortly after treatment is initiated. And one of the reasons I think is that they have unrealistic expectations. And so people need to know that it's going to be a struggle and that treatments will not work overnight, but help is available. And the vast majority of people who struggle with depression, the first thing that you try may not work for them, but with enough effort, you can usually find something that helps them either fully recover or at least helps reduce most of the symptoms.
Yeah, you talked a few minutes ago about not trying to over control or fix. And I was just thinking of maybe you've alluded to it, but maybe differentiate, if you would, a little bit between maybe the way parents would respond to children and adolescents and the way that spouses or adult friends would relate to adult friends, because they're actually very different. The role of the helper or the caregiver, there's real life for you. Somebody's at my door. There is the lost my train of thought there for a second, but just the idea that the role of the caregiver, if it's a child and an adolescent, is really different than that of an adult to an adult, whether that's a spouse or a friend. So maybe just help give a few minutes of like when it is a caregiver or parent who's trying to work with their child, adolescent, and then, with there's more adult to adult.
Yeah, great question and very good point that the approaches in these circumstances are going to be different depending on your relationship with the person and your degree of responsibility for their medical care and so forth. So for a parent, the first thing that I would say to parents is recognize too that depression can present a little differently in children, especially children prior to puberty. It's not as common in children prior to puberty, as you mentioned, Kay, but it does occur. And for a couple of reasons, the symptoms or the presentation of depression in those younger populations can look different than depression in adolescents or depression in adults. Children are not as able to readily articulate their emotional state just because of their level of cognitive and emotional development. They may not be able to describe to you what they're feeling or what they're experiencing inside very well in the way that a 16-year-old or a 26-year-old would be able to. And so often depression in children is manifested more with behavioral changes. Their mood may be irritable and angry as much as from outward appearances sad or gloomy, acting out in school in ways that are uncharacteristic, especially when that's combined with the other physical symptoms that I mentioned, changes in sleep, appetite, energy, and so forth. So your kid is starting to struggle in school. He's not focusing and paying attention. He's behaviorally acting out in ways that seem really unusual. The depression is a real possibility there. There are other possibilities too in terms of diagnoses, but that's a situation in which taking your child to see, ideally, a child and adolescent psychiatrist or psychologist, but if that's not available, at least a pediatrician to look into the possibility of depression may be warranted. And of course, as a parent, you have more authority to tell the kid, no, we're going to go to the doctor and you're going to do this evaluation, and I'm going to be involved in giving some of the history, particularly with younger children. Now, as your child gets into adolescence, there needs to be more respect for the child's confidentiality and making sure that they have time alone with the therapist where you're not sort of dominating the conversation and they have some private space there. But at the same time, you're until your child is 18, you're legally the one who consents for medical treatment. And if a doctor recommends a medication for your child, you would be the one to consent for that. The relationship with a spouse or an adult sibling or a friend is obviously very different and requires efforts aimed more at encouragement, perhaps persuasion, perhaps, setting certain boundaries in terms of my own response, but recognizing that this person will eventually have to get to the point where they want to seek help if they are going to recover. And my ability to make them do that may be limited. There are extreme circumstances, and Kay, you're perfectly aware of this, where if you're concerned that a loved one may be acting in ways that are dangerous to themselves or dangerous to others, if you're worried about suicide, or if they're so impaired by the depression that they literally cannot provide food, clothing, and shelter for themselves, then calling 911 for a mental health evaluation, the possibility of involuntary hospitalization, that might be warranted. But those are obviously the more extreme circumstances. And even in those cases, Kay, if you hospitalize a loved one involuntarily for a few days, or the family member is not actually the one who makes that decision, it will be the police officer or the emergency room physician or the psychiatrist. But if the medical professionals hospitalize a person for a few days, the period of involuntary hospitalization in most states is going to be very short. So within a relatively short period of time, the person is still going to have to get to the point where they say, yes, I recognize that I have a problem that maybe I can't fix just by my own willpower or just by my own self-administered remedies. And I'm willing to kind of entrust myself to the care of professionals and other people in my life that can help me. So it's a really hard tightrope for
Well,
people to
it
walk.
is,
It's
and
really, really difficult.
it is, and I think for family members, particularly those who maybe have had, maybe their loved one has been ill for a long time.
Yeah,
Maybe they have not gotten, they've tried lots of medications and psychotherapy, and but they have what you called retractable depression, um, which just means it doesn't respond well, even though all these wonderful interventions have been done. It just doesn't respond well. So when there's someone who has that kind of a really serious depression, maybe where there have been times where you've had to go to in an inpatient, at least for us, it just became more and more traumatic, and and
yeah,
and calling for legal law enforcement or the hospital. It ended up for us feeling like this is not the way. I mean, you're a mandated reporter. There are things you have to do by law,
right.
but I just over these years have really learned to have an appreciation for there are some situations in which I would do anything to avoid that, not because
Yeah,
Matthew wasn't in danger, not because it wasn't serious, but because I knew having the presence of law enforcement. He even said to me a couple of times in tears, "What is my crime? I'm just
yeah,
depressed." And so that was so traumatizing. I've talked to so many survivors, so many people who've attempted suicide, survivors, those who have tried to take their lives, and thank God they lived. And yet, when they talk about their experiences, and so man, it's such a conundrum for wanting to keep your loved one alive. When do you involve, even the crisis intervention team, that we have
right.
here in Orange County and other places, but also just, is there a way sometimes to sit with a person through a crisis so that it's not so much that you are, watching them, they're watching their every move, as much as you are being with them in their suffering and their pain. It's I just want anybody watching to know that there are places for those moments in which being with somebody, sitting with them through a crisis is one of the dearest things that we can do, because inpatient is traumatic. Law
Yes.
enforcement is traumatic. Um, what I've said often is that serious mental illness often leaves very few good choices. You know, we're not always choosing between good and bad. We're choosing between things that neither one feels really good.
Kay, I agree with you. I know our sheriff here in Orange County does very good training for his law enforcement officers to respond to mental health crises. But he and I have talked about the goal of getting law enforcement out of the crisis response team, so that the person who shows up does not have a badge and a gun. Um, and for certain illnesses where the person loses touch with reality, they can sometimes behave in unpredictable ways, and maybe there's a need for some level of security in those situations. But certainly with depression, or similar illnesses, the kind of compassionate response that's needed um, shouldn't require, ideally, police officers. And developing other models to try to help folks in those circumstances is really important. And in my own clinical work, I have patients that I really try to keep out of the hospital whenever possible, even when they're struggling with some degree of suicidal thinking. Um, it, let's have a 5-minute conversation every day. We're not going to do a psychotherapy session over the phone every day, but we'll touch base by phone at a fixed time every day until you get through this acute crisis, to try to avoid hospitalization. And maybe during that call, we'll talk about the possible benefits and
Yeah.
downsides of hospitalization. So I think there is a need for coming up with creative solutions that are somewhere between ordinary outpatient care and locked psychiatric unit inpatient care, to help folks avoid the kind of strain and, as you said, in some circumstances, even trauma that might be associated with involuntary hospitalization. It's a very difficult problem. I don't claim to have the
Yeah,
answers to it, but I'm
yeah,
glad that you acknowledged it.
very much so. I'm really glad here in Orange County, we've just opened, opening the very first Be Well, Orange County, the freestanding crisis stabilization unit that does not involve law enforcement. People can check in whether it's a substance use, crisis, or a mental health crisis, and they're all over the country. Those freestanding or connected, even sometimes with hospitals, where law enforcement is not involved and where people can just get that compassionate crisis care that they need. I'm glad that we're moving in that direction. But I want to shift now to, as we kind of move into our last little bit of conversation here. As I mentioned, you have a very strong faith. You love God with all your heart. I know that about you, and rereading your book just reinforced that in me. You have a very vibrant faith life, and you talk in your book about um, we've talked about the physical, we've talked about the emotional, we've talked about some relational, we've talked about therapeutic, but I really want to finish talking about the spiritual life of people with depression, especially serious depression, because you talk about in your book what you would divide as how the presence of Jesus, or how our relationship with Jesus can impact mental health, how we live with maybe depression that isn't as responsive as we would like it to be, and someone is faced with that reality of it's always there, and their suffering continues and goes on for a long time. But you said this: God is no distant figure. He enters fully into human life and redeems humans human nature, from the inside. So I wanted to talk about how does Jesus help us in that persistent suffering? But I'd also like if you wouldn't mind maybe splitting that a little bit, because in the book you talk about, I think there's words you would say to somebody who is maybe new to faith as they think about how Jesus could help them. And then people who are seasoned, they've been believers, they've been Christians there for a long time. And so they might have built a spiritual maturity. And so maybe some of the things you would say to them
Sure.
would be hard for somebody who is new to the faith. So talk to us about someone new to faith. Where is Jesus in our suffering? And then to someone who might be able to take in a little deeper. How does Jesus help us in depression?
Great questions. So I think the first thing that I would say to somebody new to faith is that if you are struggling from depression, this is not a sign of a character defect. As your husband likes to say, he's such a wizard with these little catchphrases. I might get it wrong.
That's
Your
okay.
chemistry is not your character, and your illness is not your identity, which is just a terrific way of encapsulating that idea that some Christians have the mistaken notion that suffering from depression or anxiety or another mental health problem is somehow just a spiritual problem. And I think that is overly simplistic, and I think it's not a biblical notion, certainly. So the idea that if only I had more faith, or if only I read the Bible more or prayed more, then I wouldn't be struggling in this way is not realistic, and it's not actually a Christian doctrine or a Christian idea. So I would want to kind of disabuse the new Christian of that notion, right? That faith is a panacea for all illnesses, including mental illnesses. That's just simply not the case. Once we clarified that, I would then want to acknowledge, and this kind of transitions to the group of maybe more spiritually mature or longstanding Christians that you mentioned, that depression does profoundly affect our spiritual life, right? You can imagine if you're experiencing the symptoms that we've described, how difficult it would be to pray, how difficult it might be to feel connected to the church, to the religious community of believers, how difficult it might be to sense God's presence in my life, right? and to mistakenly assume that because I cannot feel God's presence, that God is therefore absent, right? And spiritual writers will tell us time and again, and the great Christian witnesses will emphasize that we cannot gauge our spiritual progress or our closeness to God just based upon our emotional state alone, right? I pray and I get warm, fuzzy feelings. That means I'm close to God. I pray and I'm dry and distracted. That means I'm far from God. No, that's not how it works.
Right.
In fact, the latter type of prayer may be even more spiritually beneficial because you're just leaning entirely on faith and not on a kind of emotional high that God may initially draw us to him through providing more emotional and affective consolations, but then eventually, and I would say in all cases, he allows the cross, right? And we can remember those passages in the gospel where our Lord tells us that we need to take up our cross and that we are going to suffer. But of course, the Christian view of suffering is not one that says suffering is meaningless. Unlike Buddhists, we don't think that suffering is an illusion that can somehow be overcome. We believe that it's real. Christ really did suffer on the cross, obviously. We really do suffer when we have cancer, when we have depression, or when we lose a loved one. But the thing I would say to the more mature Christian, and the thing I would suggest even to the novice Christian, is that when you're suffering from depression, you are very close to Christ, even though you probably don't feel God's presence at an emotional or affective level. Christ in the Garden of Gethsemane suffered our mental anguish, right, to the point where he sweat blood. Christ on the cross reached down into all of our darkness, the darkness of physical pain, the darkness of emotional pain, and the feeling of abandonment. God really did become a man, right? The central doctrine of our faith, the doctrine of the incarnation, that Jesus wasn't just God who kind of looked like a man. He was the God man. He was fully human and fully divine. And in his humanity, his heart sometimes broke. He suffered like this in all things but sin, and depression is not a sin. Therefore, he suffered the kind of mental anguish that we suffer. And in that moment when he may feel far away because you're depressed, keep in mind the words of St. Augustine that God is, it's a very interesting formulation. God is closer to me than I am to myself. Hmm. You have to meditate on that one for a little while. He also added, and infinitely above me. So, okay, God is not just housed inside of me, but he also transcends me, obviously. But this idea that God is not a distant figure somewhere off where the stars shine. He has come so close to us in Jesus Christ, and in sending his Holy Spirit into our hearts, that he walks with us when we suffer, and we're not alone. We're never abandoned by God, no matter what, even in our darkest moments.
You talk in your book about when Jesus was on the cross, and I had it here. I may have lost it in all this. I think I did, but I was going to read it. But it was the idea that when Jesus was on the cross and he did cry out, my God, my God, why have you forsaken me? Tell us just a little bit more about that, but just what it was that Jesus, how he was able to identify with us, that cry illustrates that.
So this is a profound mystery of our faith. Let me just preface my remarks with that. And there are theologians that could put this much better than I could, but it seems to me that cry of abandonment from the cross was a real cry from the depths of Christ's heart. That yes, we have to acknowledge Jesus is the second person of the Blessed Trinity. So as God, he was never separated from God, which would be a logical impossibility. But in his humanity, in his in his human experience on the cross, he certainly felt that sense of separation and that sense of abandonment. As one 20th century theologian, Hans Urs von Balthasar, his name is kind of a mouthful, put it, on the cross, the Trinity was stretched to the breaking point, which is a very fascinating formulation. But Christ went down into the depth of human misery and even death, as far as anyone could go, in order to draw us out of that. And lots of folks will point to the fact that, my God, why have you forsaken me, is a quotation of Psalm 22, which it is. And they'll be in a hurry to emphasize that Psalm 22 ends on a note of hope, which is also true. And that needs to be acknowledged, that Christ's cry on the cross was not a cry of, it was a cry of anguish, but it was not a cry of despair, right? And so if you follow out the psalm that he's quoting, you see that it ends on a note of hope. But most of the psalm is a cry of anguish before you get to the hope. And I think it's important for us to remember that, meditating upon Christ's passion and his death can be helpful when we are suffering. Not in order to be gloomy and to focus on the sort of gloomy and a dark side of Christ's life on earth, but because that was the precondition for the resurrection. And our hope is grounded not in some rainbows and butterflies or Pollyannish view that, golly gee, everything's going to be okay. But our hope is grounded in the fact that no matter what we suffer, Christ has gone there with us, and he's closer to me than I am to myself.
Those are beautiful words of hope to end this time, that he's closer to us than we are to ourselves, and the fact that he has gone to the depths. There is no depth of misery that I could ever experience, or that any of us could ever experience, that Jesus has not also been in those depths. And that is a sweet comfort in pain. So to anyone who is, watching and listening, like Dr. Kheriaty said, you may be new to faith, and that may feel like, whoa, I don't even know how to wrap my arms around that. But if you can just wrap your arms around the fact that Jesus has been to the deepest parts of your pain, he's been there. And so he knows what it's like. And so therefore his comfort can be deeper than any comfort from anybody else on the face of this earth. He has given us each other to comfort each other, but we comfort each other with the comfort of Christ, a Christ who has been to those deep, dark pits. So thank you, Dr. Kheriaty. Thank you so much for your time with us. Thank you for sharing, your expertise about depression, but also your heart. And I think that that's the way that I visualize lots of times that what we're doing really in this life is Jesus is the bread of life. And what we have the privilege of doing is just feeding each other bites of that bread. And I feel like that our time together was, you offered us some of the bread of life, and hopefully being with us offers that back to you. Let me just pray for us as we close. Father, it is with a heart of deep gratitude that I thank you for sending your son, that you did not send an angel or some other supernatural being. You sent yourself, you sent your son. And that, Jesus, when you came knowing that you were going to go to the deepest, darkest pits that any of us could ever descend into. You would go into hell itself to experience with us the suffering, the misery, the anguish, the aloneness, the pain that becomes inexpressible. You have been there. You have walked it. You have felt it. And because of that, we can find a comfort that is sweet, because it tells us we really are not alone in this world. That even if we feel like other human beings do not completely get us, that we're a mystery to ourselves, we're a mystery to each other, even those who try so hard to understand us, to know that you fully know us, and that one day we will fully know you as we have been fully known. We're grateful. I pray for my brothers and sisters who today are on the edge. As always, God, be near them. Interrupt the intention of their heart to give up. I don't care how you do it. If it's another person who calls them, if it's a billboard, if it's a breeze on their face, if it's a song on the radio, if it's a bird in the air, God, whatever you would use to remind anyone watching that they are not alone, you are here, and that you love them. May that be their experience today. And may we fully take that responsibility to feed each other bites of the living bread, the Word of God. Jesus, we offer ourselves to you, all that we experience, all that we long to know in this life. Use our pain and our suffering and our sorrow for our own selves, but also as we minister to each other. I pray that your hope, the hope of the resurrection, will live in our hearts. And in Jesus' name I pray. Amen. Thank you again.
Thank you, Karen.
Thank you so much for being with us.
It was a pleasure. Really enjoyed it.
Thank you.